Hello students, hope you are doing good. In this video, we are going to discuss about multiple pregnancy and especially twin pregnancy, which is more common and which is most important for your exams also, right? So when we speak about twin pregnancy, it is the most common type of multiple pregnancy, as I said before, okay? So it is the most common form of multifetal pregnancy. And depending upon the time of cell division that happens after fertilization, there are nearly 4 types of twin pregnancy. Okay. So when we take the cell division time and the type of twins. So, first type where the cell division happens around 72 hours at the morula stage will be getting a dichorionic diamniotic twins, okay? And the second type where the cell division happens between 4 to 8 days at the blastocyst stage, okay? We'll be getting a monochorionic diamniotic twins. And then, if the cell division happens between 8 to 12 days, we'll be getting a monochorionic monoamniotic twins. So it is monochorionic monoamniotic twins. Suppose if due to any reasons the cell divisions happens more than 12 days, then it will be monochorionic monoamniotic, but it will be a conjoined twins, right? Okay. So more than 12 days. Okay. So this is the stage where the embryonic disc is formed, right? So we'll be getting a monoamniotic twins only, but this will be a conjoined twins type, right? So you have to remember this with the duration as well as the type of twin gestation, okay? So for better understanding, if you see this pic, you will be able to understand well. So first stage is the morula where the cleavage is happening between days 1 to 3. There you will be getting dichorionic diamniotic, okay? So chorion and amnion are the fetal membranes as we have seen in the previous videos. So we have 2 chorions and 2 amnions separately for each fetus, okay? Whereas the next cleavage, if it is happening between 4 to 8 days at the blastocyst stage, then we will be getting a MCDA twins. And if there is a cleavage is happening in the implanted blastocyst around days 8 to 13, we will be getting MCMA twins. And then if the cleavage is happening at the stage of formed embryonic disc between the days 13 to 15, that is more than 12 days, we will be getting conjoined twins. Okay, I hope I made this clear, right? Now, this is one type of classification, and we have another common type of classification for twin pregnancy, that is monozygotic twins and dizygotic twins. Okay, so we'll see the difference between them now. So it is monozygotic and dizygotic twins. See, monozygotic twin is formed when there is fusion of one ova with one single sperm. Okay, so it is 1 to 1. 1 ova plus 1 sperm. Dizygotic means, from the name itself you will get di means 2. So there is fusion of 2 ovas with 2 sperms. Okay. So fusion of 2 ovas and 2 sperms. Second one, in monozygotic twins mostly will get same sex of fetus. Okay. So same sex gender, whereas in dizygotic the gender of the fetus can be same or it can be different also. Okay, so it is sex can be same or different. Okay. So, here for example, you will have either 2 boys or 2 girls. Okay. And here you will have either 2 boys or 2 girls or 1 boy and a 1 girl combination. Okay. So, these are possible. And next one, so usually if you see the phenotype of these children as they grow, they will be identical to each other. Okay. Whereas in dizygotic, they are not that much identical. So, they are non-identical twins. They will look like just like a siblings. Okay. And that is why monozygotic twin pregnancy is also called as identical twin pregnancy, whereas dizygotic twin pregnancy is also called as non-identical twin pregnancy. Okay. Then, if we see the placenta, in monozygotic twins, there can be a single placenta or a double placenta. Okay. Whereas in dizygotic twins, there can be 2 placenta or the 2 placenta can appear fused together to appear as a single placenta. Okay. Then, the next point is the incidence of monozygotic twins is minimal. Okay. Whereas the incidence of dizygotic twins is increased. In recent days, the twin pregnancies are increased due to artificial reproductive techniques. Okay. So, due to ART techniques, this type of twin gestation is increased nowadays. And then if you see the genetic features for monozygotic twins, mostly the genetic features are same, whereas for the dizygotic twins, the genetic features are different. Okay. And then if you see the hereditary features, okay, hereditary features for monozygotic twins, mostly monozygotic twins are non-hereditary, okay, whereas dizygotic twins are hereditary in nature. Okay, that is they can pass on to the next generation. We will have more non-identical twins, sorry. Okay, and then if you see the blood type, even the blood type will be same in identical twins, but they will be different in non-identical twins. Clear? Okay. Now, you see this picture for better understanding. We have monozygotic twins, we have dizygotic twins. I already told you monozygotic means there is fusion of 1 sperm and 1 ova, where the zygote is formed and then it will be splitting up to form 2 genetically identical individuals. Okay. And then dizygotic twins means will be having 2 ovas and 2 sperms. Okay. And then they will be undergoing different stages of growth, okay, individually, and they will be forming separate placentas. Okay. In monozygotic, there will be usually shared placentas. Clear? Okay. Now, I just want you to tell differentiation between 2 terms that is commonly asked in exams. First term is superfecundation. Okay. So, remember in superfecundation, there is fertilization between 2 ova. Okay. So, there is fertilization of 2 ova. Okay. There is 2 different acts of coitus. 2 different acts of coitus. And this will be happening within the same menstrual cycle. Okay. So, there is same menstrual cycle happening. Clear? And the next one is superfetation. Now, in superfetation, what happens means there is ovulation and fertilization that is happening during an established course of pregnancy. And if you see, there will be a long gap between these 2 fertilizations. Okay. So, a long interval seen between the 2 fertilizations, and it requires ovulation and fertilization during the course of an established pregnancy, right? Okay. I hope you got it, the difference between the superfecundation and the superfetation are clear now, okay? I just want to tell about another term also, that is vanishing twin. Sometimes what happens is there is spontaneous reduction of one twin in the early pregnancy itself, okay? So, that twin is known as vanishing twin, okay? So, spontaneous reduction of a twin in early pregnancy. Clear? Now, we will see the risk factors for twin pregnancies. So, risk factors include, see, in whichever condition there is increased levels of follicle stimulating hormones, okay, more follicles will be stimulated to ovulate, and that is the time there is a increased chance of twin pregnancy or multiple pregnancy, okay. So, the key point is the conditions in which increased level of FSH are seen, okay. So, these conditions include, first one is her age, that is elderly, then multiparity, okay, she already have babies, then race, and then obesity, okay. The second high risk feature is when there is a past history of twins, okay, or even a family history of twins, okay. And then when she has undergone treatment for infertility, that is she has taken artificial reproductive technique method, okay, and ovulation induction has been done with drugs like clomiphene citrate, okay, or gonadotropins. Ovulation induction with drugs like clomiphene or gonadotropins. Clear? Now, we will start with the clinical features, okay. So, clinical features include the first trimester symptom like there will be increased chance of hyperemesis gravitorum in the women because there will be increased levels of beta HCG as well, right. And in the second trimester and third trimester as well, what happens is the uterus will go for over distension, okay, because of carrying two babies, and also there will be increased amount of amniotic fluid as well, isn't or not. So, what happens is there will be uterine pressure symptoms, okay, that can be seen due to the over distended uterus, okay. Sometimes they can exhibit symptoms like breathlessness, backache, and even some of the gastrointestinal symptoms also. Clear? Okay. And then we will go to the examination part. So, when we talk about examination, first one, we have to go for palpation. So, palpation in the first and second trimester, usually how it will be? The uterine size or more than the expected gestational age size of uterus, right. So, the uterine size is more than the expected size according to the dates, okay. And then in the third trimester, what happens is you will be able to see there is polyhydramnios and there will be multiple fetal parts palpable. Clear? And one important point about auscultation is that you will be able to hear two different fetal heartbeats. Yes? Okay. So, two different fetal heartbeats, and how you will be making this or different or distinct from each other means they should at least have a difference of 10 beats per minute. Okay, difference should be 10 beats per minute and it should be heard by two observers simultaneously. Clear? Right. Now, let's speak about the ultrasound importance in twin pregnancy. So, what is the importance of ultrasonogram? In twin pregnancy, definitely we have to know the gestational age. Yes. Then we have to know about the chorionicity, amnionicity. And definitely we have to do down screening also. Okay. So, down screening. Down screening we can do by combined test. And if it is a monochorionic twin, we have to calculate the risk for each pregnancy. Okay. So, monochorionic twin, chance result for pregnancy. Whereas, if it is a dichorionic twin, we have to calculate the chance result for each fetus. Okay. So, chance result for each fetus. Okay. Suppose if the risk comes like the risk is more than 1 by 150, then you have to go for investigations like chorionic villus sampling or amniocentesis. Clear? Okay. Now, if you ask me what is this chorionicity, chorionicity refers to the number of placentas. Okay. And after this, what we will be doing in ultrasonogram follow-up? We will be doing anomaly scan, right? So, anomaly scan is usually done between 18 to 22 weeks. Okay, right. Now, we will discuss about dichorionic twins. Okay, so if you have dichorionic twins, then you have to do growth scans every 2 weeks starting from 24 weeks. Okay, so growth scans should be done every 2 weeks from 24 weeks and fetal weight should be measured by using 1 or 2 parameters. Okay, fetal weight measured. Okay, you can use more than 2 parameters it will come. Okay, 2 or more than 2 parameters. Then AFI should be calculated individually, okay, for each fetus. So, AFI individually. Then you have to do weekly scans plus umbilical artery Doppler if there happens to be a chance of selective FGR condition in either of the fetus. Clear? Yes. Now, we will see about monochorionic twins. Okay. So, when we speak about monochorionic twins, you have to do growth scans every 2 weeks once, and you have to start it early when compared to the dizygotic twins. Okay, so you have to start scanning monochorionic twins from 16 weeks itself. Okay, from 16 weeks. And there are some unique complications associated with monochorionic twins. We have to monitor them also, right? Okay. Suppose you are doing the AFI and you find that the difference between the two scans or more than or equal to 4 centimeter, then you have to switch on to the strategy of doing weekly scans plus umbilical artery Doppler. Clear? Yes. Now, as I already told you, remember that dizygotic twins means, yes, it will be dichorionic, diamniotic. Okay, so you will be having 2 chorions and 2 amnions. Yes, and if we see monozygotic twins, you will be having either DCDA or it can be MCDA or it can be MCMA or it can be MCMA conjoined twins. Okay, and usually this is determined between 11 to 13 weeks, okay, by transvaginal ultrasonogram, which is 95 to 100% sensitive for detection of chorionicity and the type of twins. Yes? Okay. Now, these are two important signs that are seen in ultrasonogram while checking for the chorionicity and the type of twins. Okay. So, if we see the lambda sign, this is mostly seen in dichorionic, diamniotic twins. Okay. So, what you have here is, yes, you have 2 chorions, 2 amnions. That means it has developed from 2 different yolk sac and you have 2 placentas also. Okay. So, if you see the intervening membrane here, it is thick. Yes. So, if you see the intervening membrane, this is quite thick, right. So, you have a thick intervening membrane that is more than 2 millimeter in thickness, right. Whereas T sign is mostly seen in MCDA twins. Okay, and if you see this, you will be having 1 chorion and 2 amnions. Okay, but they are different, developing from 2 yolk sacs and they have 1 placenta only. Okay, so if you see the thickness of the membrane, it will be thin. Okay, can you see? So this is having a very thin membrane, that is less than 2 millimeters. Clear? So these are the important signs that you have to know for differentiating the DCTA and MCTA twins, right? Now, we will discuss about the complications, okay, due to multiple pregnancy. So, complications, we can again classify this into maternal complications and fetal complications. First, we will see about the maternal complications. So, maternal complications, okay. Why maternal complications are seen? See, there are so many changes, right? Like the uterus is much larger and there is increased secretion of HCG hormone and also another important hormone, that is HPL, is also more, and there is increased blood volume and there is increased cardiac output as well. Okay. Now, let me split these complications again into antenatal complications. Okay. So, I will split the complications into antepartum and intrapartum complications. Okay. So, antepartum complications. This can be further divided according to the trimester. So, what is happening in the first trimester, what is happening in the second trimester, and what is happening in the third trimester. Okay. So, in the first trimester, there is hyperemesis and there are more chances of miscarriage. And in the second trimester, there is gestational diabetic mellitus. Okay, because HPL hormone is also more. And then there can be preeclampsia, or because of the changes in the blood volume and cardiac output parameters, there can be chances of anemia also. Okay, increased chances. Okay, even in normal pregnancy you will be seeing it, but there are increased chances for all these conditions. Okay, so in the third trimester, there are chances of preterm labor, there can be polyhydramnios, there can be more chances of antepartum hemorrhage, and there can be difficulty in respiration, so respiratory difficulty, and there can be chances of AFLP, okay, and there can be chances of obstructive uropathy also. Okay. Next we will see the intrapartum complications. Okay. So, intrapartum complications. Again, I am dividing this according to the stage. So, in the first stage, in the second stage, and in the third stage. Okay. So, in the first stage, there can be a need for augmentation of the labor, or there can be PROM, okay, premature rupture of the membranes. There can be prolonged labor, and there can be chances of cord prolapse also. Okay. And in the second stage, there can be need for operative vaginal delivery or cesarean section. Okay. And in the third stage, there can be chances of atonic PPH because the uterus is already over distended, right? And then there can be chances of retained placenta as well. Okay. Then we will go to the postpartum complications. So, if we see the postpartum complications, there can be chances of secondary PPH. Okay. So, increased risk of secondary PPH. Okay. They may have a problem with lactation. Okay. So, lactational problems and increased risk for thromboembolism. Okay. So, there is risk of thromboembolism as well. Okay. Next is we are going to discuss about the fetal complications. Okay. So, fetal complications. See, fetal complications are more common in monochorionic twins when compared to the dichorionic twins. Okay. So, mostly seen in monochorionic twins when compared to the dichorionic twins. Okay. Now, I will split these complications again like complications that are common to both monochorionic and dichorionic twins and which are unique to monochorionic twins. Okay. Now let us see this. Now the complications that are common to monochorionic and dichorionic twins include congenital anomalies, fetal growth restriction, and there can be chances of prematurity. Whereas in monochorionic twins, there can be, we have again monochorionic diamniotic and monochorionic monoamniotic twins, right? So we'll see the complications that is happening with MCDA twins first. Okay, in MCDA twins, there are more chances of TTTS, that is twin to twin transfusion syndrome. Okay, and TAPS, twin anemia polycythemia sequence, or TRAP, which is twin reversed arterial perfusion. Okay, and then there can be selective growth restriction or single intrauterine fetal death. Okay, now we'll see about the complications in MCMA twins. Okay, so there can be chances of conjoined twins, as we have already seen, and then there can be chances of cord entanglement also. Okay, so cord entanglement. Clear? Now we'll discuss about these complications, fetal complications, one by one. So if we see the congenital anomalies, congenital anomalies are more in twins compared to singleton, okay, and it is more common in monochorionic twins when compared to the dichorionic twins. Clear? Now, what about FGR, fetal growth restriction? Okay, see, this is one of the important cause of perinatal morbidity. Okay, so it is a cause of perinatal morbidity. The growth can be normal up to 30 to 32 weeks. Okay, can be normal up to 30 to 32 weeks. Okay, after this, even then there is no associated complication with the twin pregnancy, the growth curve will slow down. Can you understand? Yes. So after this, the growth slows down even in uncomplicated twin pregnancies. Okay. Okay. Now we'll see about twin to twin transfusion syndrome. So TTTS. Okay. Twin to twin transfusion syndrome occurs due to deep arteriovenous anastomosis. Repeating. We'll see about TTTS. So TTTS is nothing but twin to twin transfusion syndrome. Okay. So here we'll be having deep arteriovenous anastomosis. Okay. What happens is the blood will be flowing from one twin to the other twin. Okay. That means the flow will be in a single direction only. Okay. So blood flows from one twin to the other twin, or the first twin to the second twin, in a single direction. Okay. So that means what? It is a unidirectional flow. It is a unidirectional flow. Okay. So now I am naming the twins as donor twin and recipient twin. Okay. So if we see, the first twin is named as donor twin, the second twin is named as recipient twin. Okay, because the blood is going to flow in this direction. Okay, now with this idea, we are going to bring out the differentiating features between these two twins. Okay, so what is happening with the donor twin and recipient twin? Donor twin is going to pass down all its blood to the recipient twin. So what is going to happen? There will be, yes, there will be anemia in donor twin, whereas there will be polycythemia in the recipient twin. Okay, and the next important point is in donor twin you will be able to see oligohydramnios. Okay, whereas in recipient twin there is polyhydramnios. Okay, and then in the donor twin, because it is deprived of all the nutrition, there will be FGR. Okay, that is fetal growth restriction in the donor twin, whereas in the recipient twin there will be circulatory overload. Okay, circulatory overload. Okay, so that can even result in thrombosis. And remember that donor twin can also be associated with contractures. Clear? Okay. What happens in the donor twin is, if there is severe oligohydramnios, the membrane appears to get attached to the fetal body parts, and then this twin will be known as stuck twin. Okay, and also remember, if either of the twin dies, okay, there will be severe hypotension that will be resulting in multi-organ failure and neurological damage in the surviving fetus. Okay. Okay, now let's see this diagram for better understanding. So if you see this, you are able to see one fetus to have anemia and the second fetus is having polycythemia. Okay, so which will be the donor twin? Yes, this is the donor twin and this is the recipient twin. Okay, and if you see, there is, if you zoom this picture, you are able to see there is deep arteriovenous anastomosis that is present. Okay, so there is passage of red blood cells through these vessels. Okay, and increased RBCs and increased hematocrit in this twin leads to thrombosis. Okay, whereas if you see this picture, you are able to see that there is polyhydramnios. Yes, more like are present. Here there is severe oligohydramnios. Okay, that will be making the fetus get stuck with the membranes. Okay, so it seems like the fetal membranes are getting stuck to the twin. Okay, stuck to the baby. Okay, repeating. So it seems that the membranes are stuck to the fetus. Okay, so this is also known as stuck twin. Clear? Yes. See, this staging is given to quantify the severity that is arising in the TTTS syndrome of monochorionic twins according to the sonograph assessment. Okay, so we have 5 stages: stage 1, 2, 3, 4 and 5. Okay, in the first stage, simply we have oligohydramnios and polyhydramnios stage. Okay, so stage 1, the donor will be having oligohydramnios and the receiving twin will have polyhydramnios. So it is the single vertical pocket in the first twin will be less than 8 cm and a single vertical pocket in the second twin, okay, will be more than 8 centimeters. Okay, in the second stage, remember the donor bladder is not visible, right? And in the third stage, we will be able to see some abnormality in the Doppler. So there is abnormal Doppler in the third stage. And in fourth stage, we will be able to see hydrops, okay, in either twin. And in the fifth stage, there will be demise, okay, of either twin. Clear? Okay. Now, if we speak about the management of TTTS syndrome, if left untreated, the mortality rate will be around 80 to 100%. Okay. So, suppose if you discover this complication in stage 1, okay, you are going to do a expectant management mostly. Okay. Suppose there can be a need of serial amnio reduction in the second twin, that is the twin with polyhydramnios. Maybe you can start it after some 28 weeks. Okay. And if it is discovered in this stage 2 to 4, okay, you can do laser ablation of the vessels by fetoscope. Okay, because the vessels are communicating. Okay, so that communication has to be ablated. Okay, and this can be done if it is less than 28 weeks. Okay, and anytime after this, you can plan delivery between 34 to 36 weeks after giving steroids. Okay, so to summarize, how we have diagnosed the TTTS? First one, we checked the amniotic fluid index. Second one, where we can even check the MCA Doppler, right? So Doppler can be checked. Okay, MCA, peak systolic velocity. Then you can check if either of the fetus have hydropic features, or sometimes fetal echo can also be done because the recipient can go for cardiac dysfunction. Okay, so that is circulatory overload, right? So cardiac dysfunction in the recipient twin. Yes? Okay. Now, we will see about the next complication, trap. Okay. Now, this is twin reversed arterial perfusion. Okay. So, this is one of the rare complications that is seen in 1 by 36,000 deliveries. Okay. Here there is a communication of artery to artery or vein to vein. Okay. See, what is going to happen in this trap is, here also you have a donor twin and a recipient twin. The donor twin is going to pump deoxygenated blood into the umbilical vessels of the recipient twin. Okay. So, in the fetal circulation we have learnt that most of the deoxygenated blood goes to the lower half of the body in the fetus, right? So, what is going to happen is the lower half of the second fetus develops, that is the recipient fetus develops, but the upper half including the head, body and the heart, it's not going to develop. Okay. So, donor pumps deoxygenated blood into the umbilical vessels of the second twin. Okay. So, what is going to happen? The lower half develops, whereas the upper half including head and heart does not develop normally. Okay. So, due to this, what happens is this donor twin even develops cardiac failure. Okay. And this has a high mortality rate also, around 50%. Okay. Yes. Next, we'll see about the management of this complication. So, you can ablate the umbilical cord vessels by either laser or diathermy. Clear? So, here you are able to see the trap sequence. Okay. So, this is going to be the, yes, this is going to be the donor twin and this is going to be the recipient twin. Okay. So, there is a connection here. Okay. And what is going to happen is the lower half alone is going to develop in the recipient twin and it is avoid of the upper half of the body including the head and the heart. Okay. Yes. We'll go on to the next complication, that is twin anemia polycythemia sequence. It is TAPS, okay, which is nothing but twin anemia polycythemia sequence. Okay. So, now this is one of the uncommon condition. Okay. It can be seen only in 5% of the cases. And if you see, there is arteriovenous anastomosis here that is present in the small vessels of the placenta. Okay. Seen in the small vessels of the placenta. So, definitely from the name itself you would have got the point now. We have a donor twin and we have a recipient twin. Okay. So, donor is going to develop anemia and the recipient is going to develop polycythemia and it appears to be suffused. Clear? But one major difference we have to note here is there is no significant difference in the amniotic fluid volume. Okay. And if you see USG, twin A will be having the MCA peak systolic velocity more than or equal to 1.5, that denotes anemia. So, this is going to be a donor twin. Okay. And twin B MCA peak systolic velocity is going to be less than or equal to 1, which denotes polycythemia. Okay. That means this is going to be a recipient twin. Okay. And sometimes IUD can also occur. Okay. So, intrauterine death chances are also more. Okay. Sometimes this condition can be discovered postnatally also. So, when you see postnatally, the hemoglobin between the two fetuses will have a difference more than 80 gram per liter and the reticulocyte count will be having a ratio more than 1.7. Okay. And then now this is a picture to know about the TAP syndrome. Okay. So, if you see, the amniotic fluid volumes are not going to change in any way, but there is a connection between the small vessels between the two fetuses. So, one is going to be anemic, okay, and another one is going to be polycythemic. Clear? We will see about the next complication now, that is selective FGR. Selective fetal growth restriction. Okay. So, this is seen in 10 to 15% of the cases due to unequal placental sharing. Okay. So, there is unequal placental sharing. So, if you see twin A, it can be completely normal. Okay. Whereas twin B will be having a fetal weight that is less than 10th percentile of the normal fetus. Okay. and this can be confirmed by seeing a difference in weight that is more than or equal to 25%, okay, in comparison to the normal twin. Yes. So, if you see in selective fetal growth restriction, you will have oligohydramnios in one twin and a normal amniotic fluid levels in another twin. Okay, whereas we have already seen what's happening in twin to twin transfusion syndrome. We have oligohydramnios in one twin and yes, polyhydramnios in other twins. Clear? Yes. So, we will see the complication that arises when there is a selective intrauterine death of one fetus. Okay. See, there can be placental vascular anastomosis present, okay, in these complications in which we have discussed before. So, due to this, if one twin dies, the surviving twin will go for acute hypotension. Okay. So, there also be hypoxia in the survival twin because there will be a sudden low pressure system developing in the surviving twin. Yes? System. Okay. So, in this situation, the risk of death of co-twin, okay, that is the surviving twin is around 15%, okay, and there can be chance of neurological abnormality that can be seen in 25% of the cases. And after 34 weeks means we can plan delivery, okay. And also you have to perform fetal brain ultrasound or MRI, okay, 4 weeks after the fetal death. Clear? So, you are not going to urge the delivery here, okay, you are going to just monitor because we have already seen the risk of death of co-twin is only around 15%, but the chance of neurological damage is more. So, you are going to monitor them with MRI and fetal neuro ultrasound, okay. Then, next is cord entanglement. Suppose if cord entanglement is seen between the two fetuses, you are going to deliver them between 32 to 34 weeks, okay, and the delivery mode will be cesarean section. Clear? Now, we will see about conjoined twins. So, when we speak about conjoined twins, it is seen in 1 in 1 lakh pregnancies, okay. The twins can be connected at any level and they can even have shared organs, okay. So, how will we be doing the diagnosis? Yes, obviously ultrasonogram, and if diagnosed early, termination is advised as soon as it is diagnosed. Clear? Okay. Now, suppose if it is found only in the 3rd trimester, then you have to plan delivery between 32 to 34 weeks. Clear? So, this is a picture to know about the various types of conjoined twins. Thoracophagous, where they are joined at the level of thorax, and omphalophagus, where there is a joining at the level of umbilicus, and then cephalophagus joining at the level of head, then ischiophagous at the level of ischium, pyophagus, where they are attached in the torso, okay, then craniophagous, where they are seeing each other and the head is just attached. Then you have paraphagus dicephalus and paraphagus disporus also, okay, and also rachiphagus. Clear? Now, if we see, the most common type of conjoined twin is this paraphagus, okay. So, this is the most common type, whereas rachiphagus is the least common type of conjoined twins, okay. So, this is more than enough. Now, we will see how we are going to plan delivery. Okay. So, when planning delivery for DCDA twins, you have to plan delivery around 37 weeks. Okay. Suppose if it is an MCDA twin, you have to plan delivery around 36 weeks, and for MCMA twins, you have to plan delivery between 32 to 33 weeks. Clear? Now, how you will be deciding the mode of delivery? Okay. So, mode of delivery is mostly defined by the presentation of the first twin. Okay. So, if it happens to be cephalic presentation in the first twin, you can plan vaginal delivery. Suppose if it is breech or transverse or anything else, okay, then you will be going for cesarean section, right? And after delivering the first twin by cephalic, after delivering the first twin by vaginal delivery, if it is a cephalic presentation, you have to check for the second twin presentation, okay. So, after delivering the first twin by vaginal delivery, if it is a cephalic presentation, you will be checking the presentation of the second twin, okay. The second twin can have vertex presentation itself, that means vaginal delivery becomes easy and possible, and the second chances that it can have a breech presentation. So, if it's so, you can go for assisted breech delivery, or otherwise it can even have a transverse line, okay. So, this is the only indication in obstetrics, that is when the second twin is in the transverse line, you are going to do a internal podalic version, okay. So, you are going to do a internal podalic version. This can be done under general anesthesia in a OT setup itself, okay. And you can go for a breech extraction. If not possible, you can even proceed on to the cesarean section. Clear? Yes. So, now some of the important points. So, maximum time gap between delivering the two fetuses should be around 30 minutes, okay. And then don't give uterotonics after delivering the first twin. Uterotonics are not recommended after delivery of the first twin, okay. Suppose if you have the first twin in a breech presentation and the second twin in a cephalic presentation, okay. See, so this is going to be in a breech presentation, okay, and this is going to be in a cephalic presentation like this, right. So, what happens is, if you allow delivery of the breech delivery of the first twin, okay, when it descends down, there will be interlocking between the two twins, okay. So, interlocking happens, okay, if you allow vaginal delivery when the first twin is breech, okay. So, always remember to do a cesarean section when the first twin is in a breech presentation. Clear? Okay. Now, what are the management measures that you need during intrapartum care? Okay. So, during intrapartum, definitely expect PPH. So, the mother should be secured with IV lines and blood transfusion precautions should have been taken. And for the fetus, you have to keep one ultrasonogram nearby to see the presentations even after, during the labor progressing, and also to monitor the fetal heart rate, okay. And you have to give a dual CTG monitoring also, and this should be assessed every hourly, okay. The mother can be given epidural analgesia if you are allowing a vaginal delivery, or a regional analgesia if you are planning a cesarean section. Okay, and definitely during the third stage of labor will be performing AMTSL, that is active management of third stage of labor. Okay, no doubt in that. Okay, and then what are the other measures? What are the other follow-up measures we have to initiate from the beginning? For the mother, okay, we will be measuring full blood count at booking visit, then around 20 weeks and again by 28 weeks at least. Okay, there is increased chance of preeclampsia. Okay, so you have to check for the BP and proteinuria, and the mother can be started on prophylactic aspirin at a low dose 75 to 150 milligram per day, and this can be initiated from 12 weeks till birth of the baby. Okay, and the indications of starting aspirin include some of the risk factors also. Risk factors include if it is a first pregnancy with a twin gestation, and if the age of the mother is more than 40 years, then pregnancy interval between her two deliveries is more than 10 years, then if she is having a BMI more than or equal to 35 kilogram per meter square at her first visit itself, and then she has a family history of preeclampsia. Okay, if you have even one features, one or more than one risk factors, you have to start her on aspirin. Clear? Right. And don't forget to give antenatal corticosteroids. Okay, depending upon the gestation and the complication. Okay, yes, that's it. We are completing a twin pregnancy. Now, until we meet in the next video, take care, happy learning, and bye-bye.